please.
Thank you very much, Mr. Chairman, and thank you for the organisation for the honour of presenting this afternoon. I've been given a bit of a poison chalice to talk about the real issues with centralisation, and I thought that I would start by going back to the real genesis of centralisation, which is this initial paper by John Birkmeyer published in the New England Journal in 2002. And in the right-hand corner you can see the figures for pancreas, which was considered to be a eureka moment. If you can go back to that slide, you'll see that the mortality for low centres was 16%, down to 3.8% for high volume centres. So the eureka moment was that if we centralised complex surgery such as pancreatectomies to high volume centres, it would lead to better patient outcomes. So what we thought was relatively simple is actually quite a complicated issue. And so the first question is, does centralisation actually reduce the perioperative mortality associated with pancreatic surgery? What actually does the patient want? And are there economic implications? And what about the other specialties? We've just heard John the ophthalmologist very eloquently argue a case for adjuvant chemotherapy. What about neoadjuvant chemotherapy? What about diagnosis? And I'm going to speak a little bit about the Irish experience. This has all got to be taken into the context of what we've done over the last decade in pancreatology, and in particular with pancreatic surgery. Our perioperative mortality and morbidity has decreased because of a number of issues. We've got better perioperative care, we've enhanced recovery programs, we've got used limited or nasogastric tubes, limited or no abdominal drainage, early feeding, early ambulation, ERAS type programs in pancreatology. We've improved diagnosis and staging, so we're taking patients to the operating room who we think we can benefit from an operation. And also we've got more accurate pathology, and we're into the era of molecular medicine. So to bring us to where we are today in Switzerland, this is the impact of centralisation on hospital mortality in Switzerland. It's from the inpatient database of the Swiss Federal Statistical Office, and it was published in the Swiss Medical Weekly last year. 2,668 patients. The vast majority, as you can see, have been operated in low-volume hospitals. They equate low-volume hospitals to hospitals that have less than 20 cases per year. The mortality was 5.4%, and those operated in hospitals that had a high-volume centre, i.e. more than 21 cases a year, the mortality was 2%. And if you look at the effect of centralisation, you can see more patients are being operated on seem to be operated in higher volume centres, but this number is only 8, so 8 per year. And you will see down here, if you can see, that there's still 41 centres operating in pancreatic surgery within Switzerland. Hospital volume and mortality also decreases, and these are the high volume centres with a mortality around 4%. These are the low volume centres with a mortality around 8 to 9%. So it seems to work, but you're still talking about a lot of hospitals doing very little surgery, with the majority of patients being operated on in low volume hospitals. So is that unfair for Switzerland? Well, if we move north a little bit into Germany, this is data that was published this year from the Annals of Surgery. 61,000 patients of major pancreatic surgery, national hospital data, and they put them into quartiles from very low, or quintiles very low, to moderate, to high, to very high. If you take these two centres, you're talking about 55 centres, and if you take these, you're talking about nearly 550 centres, which have a volume of between 5 and 10 cases, and these, of course, can have a volume of a very large number of cases. If you look about mortality in this lower column, or this lower table, you'll see that the mortality in very low hospitals, adjusted mortality, is 11.5%, as compared to 6.5% in very high hospitals. And this is irrespective of whether the operation was done for malignant disease, for benign disease, or for neuroendocrine tumours. So it suggests that there is a volume outcome relationship within Germany. And there's been other studies which have confirmed that most of the data shows that there's a strong inverse relationship between the amount of cases that are done in a centre and the mortality. But it is complicated because within the centres that are doing a lot of surgery, you've got specialists who are expert in doing the operation. So operative performance is important. And also within those centres, there is a complication rate, and most of us recognise that our cases where we do pancreatology and pancreatic surgery come with a high morbidity. And part of the key of doing it well, I tell my residents, is to recognise complications before anyone else recognises the complications, and then when complications occur, rescue those patients. And the failure to rescue is a big issue. But what's happened in Germany? Well, the mortality over the last decade has really stayed the same, around 8 in the high 8%, maybe 9%. And if you look at the proportion of patients operated on between low volume hospitals to very high volume hospitals, that's the very high at the top, the majority of patients are operated on in low volume hospitals. 80% of people are operated on either in low or in very low or in low volume hospitals. So centralisation hasn't worked. So if we go north and west, or just go west into France, and what's the situation in France? This again was published by Olivier Farge in 2017 in the Annals, a nationwide observation study between 2007 and 2012, quite contemporary. 23,000 patients operated on for pancreas surgery, of which 12,000 had a pancreatic duodenectomy. The post-operative mortality overall is 8.1%, and for pancreatic duodenectomy, the post-operative mortality, perioperative mortality is 9.2%. If you take low volume versus very high volume, the odds ratio of dying if you're operating in a low volume hospital is actually 1.86 times. There are 456 hospitals in France doing pancreas surgery where they define as low volume, less than 25 cases. And between 2012 and 2017, there has been a slight change, but still 50% of patients who are operated on are operated in low volume hospitals, and the majority of those low volume hospitals do less than 5 cases per year. When you look at the higher volume hospitals, there are 20 centres between 26 and 65 cases per year, and 9 centres over 65 cases a year. And the percentage of those patients operated in those centres and the split between those two groups has not changed between 2007 and 2012. The authors make the point that these large volume centres, the greater than the 65 centres, are spread around France. And they suggest that centralisation into these centres is impractical because of professional, cultural, and economic issues. So they feel that centralisation in France has reached a point where one has to consider empowering other hospitals to do pancreatectomy. Now, if we go north from France and into the Netherlands, what has happened in the Netherlands? So we have low volume, high volume, and medium volume hospitals. And what you see is nothing really happened up until 2007. And in 2007, the Healthcare Inspectorate suggested that the minimum number of cases that could be done in an institution was 10. In 2011, the Dutch Surgical increased that to 20. And as you can see, when this happened, there was a nodal point, and more patients were beginning to be operated on in high volume centres. So there was the volume of operations in the Netherlands increased from 170 per year to 621 per year, and the number of centres decreased from 41, but still 38 centres do surgery. What may change this further is what's happened here in the insurance industry, because the insurance companies now have set a minimum volume standards for reimbursement. And I think that's going to have a major effect. And as you can see, both these curves are going down. So does it make a difference? An earlier study from Holland showed exactly the same thing. So in low volume hospitals, the mortality was higher than in high volume hospitals. And then when you looked at overall survival by the period of the earlier period before centralisation and post-centralisation, the curves separated, but there was no statistical difference. However, when you looked at high volume hospitals versus low volume hospitals, there appeared to be a statistically significant difference in terms of overall survival for patients. Now, there are a myriad of different diseases in here, and we'll go through the functional health status in a moment. This shows the functional health status, and I think this is an interesting article. It was one of the first articles that pointed it out. It was from Eindhoven. They took peripancreatic tumours, and they compared university teaching hospital with community hospitals. And what they showed, initially there was a 1-year survival difference, but that at 2 years it was equal enough. But what they did show was that the patients who were operated on in the university hospital happened to be younger, they happened to be male, they had a lower Charleston comorbidity index, and they were of a higher socioeconomic status. So the functional health status does make a difference and does play in. What's happened in the United States since the Birkmeyer paper over here? So what you have over here is the high volume hospitals in blue, medium hospitals in green, and the low volume hospitals in red. So the volume of cases in the low volume hospitals has decreased. The volume of cases in the high volume hospitals has increased. What's happened to adjusted mortality, though, is interesting. Because if you look at the low volume hospital mortality, that is actually now merging with the medium hospitals and is close to the high volume hospitals. In fact, the difference in adjusted post-operative mortality at 90 days is only 1% now, 1.25% between the very highest quartile of hospitals and the very lowest quartile of hospitals. And remember, there are 962 hospitals in the United States who are doing low-volume surgery compared to 3% of hospitals. So what the authors in this recent paper have said, published in Journal of the American College a couple of months ago, they've said that global improvements in perioperative care, which we alluded to earlier, coupled with better protocols, have actually led to an extension of care and an improvement in care across the board, and that possibly should centralization be extended to mid-volume hospitals. So what does the patient want? Now, this study is interesting because it's one of the few studies that actually looks and has actually asked patients what they want in terms of care in pancreatic surgery. It's published in BMC Cancer 2 months ago. And what it said was, from the patient's perspective, they want a highly trained staff, they want their waiting time to be minimal, they have a low likelihood of complications, and they want to have access to the various disciplines of staff. Now, actually, when you look at what healthcare professionals want and what the system wants, it's actually very similar. Those things move around. It's interesting, one of the things that surprised me about this survey, because in my experience, the patient wants to know that the cancer will just disappear and that they'll actually live, and yet it's not in this story. So what is interesting, what they seem to be saying is, we want to be treated in a center that has all the bells and whistles of an academic center, that has the diagnostics, has the perioperative care, has access to excellent surgeons, has excellent post-operative care, and then I can see the ancillary specialists. And again, if you look at data from the National Cancer Database in the United States from this time period, from 98 to 2011, this has 33,000 patients who had stage 1 and 2 adenocarcinoma of the pancreas. And the survival difference between low-volume hospitals is 11.2%, academic medical centers is 16.6%, and the median survival goes from 12.5 months to 19 months. So it seems to make a difference. But, and there is a but, when you look at all the factors and all the variables in these patients, and I want to focus on this slide on the tumor variables, they seem to have different disease. If you're being operated on in a community hospital, by and large, your disease is going to be more advanced, you're going to have a higher prevalence of node positivity, margin positivity, fewer patients are going to have access to radiotherapy, fewer patients are going to have access to chemotherapy, and the mortality and morbidity is high. So again, not only is the functional health status different, but when we interpret this data, we have to pay credence to the fact that the oncological data may be different. So what happens, what gets people into high-volume hospitals? This is an excellent paper in the Annals of Surgical Oncology from Dr. Wasif, who's written extensively on this topic. Again, using the National Cancer Database. Again, time spans a little bit different, numbers are a little different, but they're significant numbers. Again, these are patients with stage 1 to 3 pancreas cancer. Getting to an academic medical center, you're going to travel more than if you go to your community hospital, which is down here, and a mid-volume hospital down here. But it is important to recognize that these patients within the United States are going to be Caucasian. They're going to live in a metro area rather than a rural area. They're going to have good comorbidities. They're going to have an educational attainment more than high school, and in fact into third-level college. They're going to have a median income which is greater than $46,000 a year. they're going to be insured. In other words, again, getting back to the earlier Eindhoven data, it suggests that these patients are a different class of patient in terms of their socioeconomic class than the patients who go to the local community hospital. Now, what does that have an impact? And it does indeed have an impact. Again, if you look for the cost of this, if you look at the low volume hospitals, the length of stay is higher, the extended length of stay is higher, the hospital mortality is in this study is 5% versus 3%, the failure to rescue is 11% versus 8%. But when you look at the costs actually for the government, for the national cost, it's actually cheaper to have all this care, despite all the complications, in the low volume hospital. And you think of, well, how could that be? Well, one of the things are that high volume hospitals come from a lot of fixed costs. They have bigger radiology departments, they have bigger operating theatre departments, they've got more fixed costs, and their variable costing is higher. And even if you take the patients who have a complication, remember I said, if you have a complication, you're lot more likely to have a successful rescue in an academic high volume centre, except it's going to cost you more, again, for those other reasons. So there's been a systematic review which has looked at the whole economics of centralisation, and across the original high volume Berkmeyer studies, esophagectomy, thoracic cases, and pancreatectomy, 13 studies suggested that surgeon volume was associated with cost reductions. One study demonstrated that quality-adjusted life years actually was positive for pancreas surgery to the value of €3,600. 4 studies actually reported that all 4 studies who looked at costs associated with patients showed that for the patient to go to a high-volume centre, that they have more costs. And when you look at those, 3 of those studies looked at pancreas, and what they said was the visits for each individual outpatient visit cost was about €7 per visit increased for the patient, but the travel costs were substantially higher. The last one of these is this Sitzenberg study from New York. It took New York, New Jersey, and Pennsylvania, again up to 2006. They had 13,000 patients with pancreas cancer. And there was a shift over the time period from 1996 to 2006 from low volume to high volume providers, as shown up here. This is the high volume providers, and you can see the bar chart there shows a significant increase. What they also showed, this is pancreas here, there was a 40% increase in the travel distance that patients were required to do going forward. What Sitzenberg also said, well, why are these patients willing to do this, or what makes a patient stay in their local hospital? And again, it comes back to the data I showed earlier. These patients are usually living in an urban environment, they're usually Caucasian, they usually have private health insurance, and they are, when they look at the poverty index, they're less likely to be socially affected. So what we can say about the economic data that exists to date is it's of poor quality. And really, we do not have any good data to suggest that centralisation results in economics of scale and is cost effective, either for the patient, well, we think it may increase the cost of the patient, but to the healthcare provider and to the state. And in Europe, that's important, as the state is the provider in the majority of our countries in terms of healthcare funding. Now, there's this thing called the Cobra effect. And this is anecdotally comes from the British Raj in India, in Delhi, where they were trying to cut down the amount of cobras. And they thought the way of doing that was to put a bounty on the cobras. And the good citizens of Delhi were very smart, so they said, well, the British are paying for each cobra, so let's go and farm cobras and just get more and more cobras. And so the British budget was blown because all these cobra snakes were coming in. And so then the British said, well, we can't do this. So they stopped the program, but yet they had this huge increased number of cobras. So the program was a complete negative disaster simply because the intended input had an undesirable effect. So if I stand back and look at Ireland, in Ireland in 2002, there were 3,700 hospitals within the Republic of Ireland, a population of about 5 million people, providing cancer surgery. Clearly, this is unacceptable. The government in 2006 did a very informative program and said, we're going to form a national cancer forum, we're going to look at cancer care, In 2006, this report was published, and in 2007, the Irish government said cancer care surgery is going to move from these 37 hospitals down to 8 hospitals. And furthermore, later in 2009, they said not only is cancer surgery going to move, but pancreatic cancer surgery is going to move to 2 centres. Centre I now operate on St. Vincent's University Hospital as the main centre, and a satellite centre in the Mercy University Hospital in Cork. So we went from 37 hospitals, all doing a little bit of everything, many of them doing pancreas surgery, to 2 hospitals doing pancreas surgery. Now, this is the heat map of pancreas cancer within Ireland. The demographics of pancreas cancer are exactly the same as elsewhere. It's a tumour that affects patients in their 7th and 8th decade of life. It's majority of patients present with distant disease. And in Ireland, the majority of patients present within the Western Seaboard. This is Dublin, the capital of Ireland, where St. Vincent's University Hospital is, and this is Cork, the second city in Ireland, where Mercy University Hospital is set. So what we've seen in terms of disease-specific survival, and this is from the National Cancer Registry data from this year, that if you look at the period where we've now had specialisation, there's been a modest increase in disease-specific survival from 6.1% to 7.9% 5-year overall disease-specific survival. So that's good, but again, it's multifactorial as to why that's happened. And part of the problem is we've focused on this concept of surgery, with removing everything else that goes on with the patient. And this is, identification, the diagnosis, how you diagnose them, any of the trials that we're doing, neoadjuvant chemotherapy, adjuvant chemotherapy, complications, getting back into the system, and the quality of life issues. So we've focused completely on surgery. And what we've seen since 2007 is there has been no change in either the incidence of the disease, which you wouldn't expect with centralisation, but there really hasn't been a change with the overall mortality of the disease. What we have also seen is that when you look at the patients who are diagnosed with pancreas cancer, 60% receive some form of therapy. Now, this does not mean they have resectional therapy. This does not mean they have quote-unquote curative therapy. This means they have any therapy. And this is the numbers. 14% undergo surgery, and that can be palliative surgery, it can be resectional surgery, 10% radiotherapy, and 35% chemotherapy. So now you begin to think, well, hold on a second, you've got these cohort of 500 patients, and yet 60% of them are only being treated for their disease. So what is the issue? Well, we may have some answer from our own centre. And I think given the excellent talk that John the ophthalmologist gave in terms of adjuvant, neoadjuvant therapy, and he made the point that 60% resectability is unacceptable because it's very low. I would argue that 60% is actually quite high, and in the real world, the resectability rate after chemotherapy is much less. So this is a study that we presented at EHPBA last year and is currently in press. We had 93 patients that were identified as having borderline resectable disease. We came down to, with one thing and another, and I won't go through the study, that 53 patients were having the neoadjuvant therapy, and we came down to, at the very end, that 34 patients out of that group were now considered to be resectable after they had neoadjuvant therapy. And of those, 21 patients were resected. So I suppose you can calculate the resectability rate at 21 over 34, you can calculate it at 21 over 53, or you can calculate it at 21 over 93. That's not what I'm here for. What I'm here to show you is this next slide, because I think this illustrates some of the issues with centralisation that we have to grapple with. The first is, again, Dublin here, Cork here, all the patients over here. The treatment, current acceptable adjuvant therapy or neoadjuvant therapy for pancreas cancer includes 2 main chemotherapy arms, FOLFIRINOX and gemcitabine and nab-paclitaxel or Abraxane. And yet, in our study, when we see the patients in the MDT, we determine by the NCCN criteria that they're borderline resectable disease, and we say that this patient needs neoadjuvant chemotherapy, that within this group of patients, only 60% of the patients had, which would be considered the 2 main arms, FOLFIRINOX or gemcitabine. 40% had other treatments. And that has a direct effect. When we look at whether the patient was seen and treated in our institution, their survival rate was better than if they were seen elsewhere. Overall, in the group, It's quite a small, low survival. It's 17.5 months versus 12.9 months. But when you look, and the numbers are small, so that's not statistically significant, but there's clearly a trend there. But when you look at whether or not they received the FOLFIRINOX gemcitabine chemotherapy versus the other chemotherapies, there's a major difference. There's a difference between 26 months survival versus 12.9 months survival. There's also a difference in terms of resectability. So what we're seeing here is the centralization should not just be applied to surgeons alone, and that the impact on the patient in terms of diagnostics, and I could show you time to scanning and how that affects survival. We've done that data. But in this case, the impact of developing the neoadjuvant chemotherapy regimens and adhering to protocols is different if you're treated in your academic center or your community center. And this data is replicated in other countries as well. And it doesn't reflect the quality of the medical oncologists in the community or non-academic centers. Very often these are excellent individuals, they're up to date with the literature. It's just that their system is not equipped to deal with the complications that you can get, as we all know, with FOLFIRINOX. So it's an issue that has to be dealt with. So in summary, what I would say, what was thought to be simple is actually quite complicated. We need to complete this process of centralization, or understand, as the Americans are beginning to tell us that we should understand, and the French are alluding to it as well, that we should understand the principles of centralization and apply it to lower volume hospitals to improve patient outcome. We need in some way, as a central governmental affair, if we are centralization, we can't pass those costs on to the patient. We need to include in centralization diagnostics as well as adjuvant and neoadjuvant therapies. And one other issue is we need to understand that if a patient goes to a remote center, goes home in a rural area and has a complication, that there needs to be a quick pathway back to the mothership. In other words, we need to be able to rescue complications. And the other unintended consequence of centralization is that benign pancreatic conditions have suffered. As the expertise and the willingness to treat patients in non-centralized centers occurs, this is affecting, I believe, the outcomes for severe pancreatitis, necrotizing pancreatitis, and also some issues with chronic pancreatitis. Do I have data to prove that? No, but I think we can see that anecdotally in our system. So, has centralization of pancreas cancer surgery improved disease-specific survival? I think the jury is certainly out. I think if you have the operation in the center, treated in the center, for that cohort of patients, the answer is yes. But for the vast majority of patients in our countries who develop pancreas cancer, it's certainly an unanswered question. Mr. Chairman, again, I'd like to thank for the opportunity of speaking to you. And finally, I'd like to advertise our EHBBA Congress in Amsterdam next June. This is going to be an excellent meeting. The title of the theme of the conference is evidence-based medicine, and this, of course, is a topic that we'll be discussing further there. Thank you very much.